Spring is in the air. Welcome to the Urgent Care Association Solutions on Demand webinar brought to you by HealthTrackRx. Today we're going to talk about the role of rapid multiplex PCR to optimize clinical decision-making for outpatient infections in the urgent care. We're going to discuss cases today that are unique to spring and summer. Kids come home from spring break, we see an increase in STIs, and as temperatures heat up, traditionally there's an increase in urinary tract infections as well. I'm your moderator, Ben Favre. So to get through these cases today, we're fortunate to be joined by two experts in molecular infectious disease. First, we have Ali Prego, a clinician at Modern Pediatrics and also a medical science liaison at HealthTrackRx. Ali, how are you doing today?
Doing real well. Excited to be here.
We also have Dr. Stephen Goldberg, who's an urgent care practitioner at University of Louisville Health and is also the Chief Medical Officer of HealthTrackRx. Dr. Goldberg, how are things going today?
Awesome, Ben. Excited to be on this panel with you and Ali.
So Dr. Goldberg, I want to start off by just kind of orienting everyone on PCR. And it seems like during COVID, everybody on earth was getting a COVID swab and a PCR test. Can you level set, give everybody a good idea of what PCR is so we're on the same page here?
You bet, Ben. We learned a lot about diagnosing accurately to inform treatment during the pandemic. And PCR was a very important tool. Since that time, we've looked at a broader range of infectious disease applications for PCR, and we'll talk about a few of them today. So a quick 90 seconds on multiplex PCR as a diagnostic test, because we know that could be a topic in and of itself. Basically, what PCR does is it looks for the DNA or RNA in an organism. So it's very, very accurate. And the way that's done is first you collect a sample, and that's done in the exam room with the patient. Then you put that sample in a preservative, and that's often done at the medical assistant station. Then either point of care platform in the office or at a send-out lab, the RNA is extracted. And then finally, in a point of care test in the office or at a send-out lab, there is a multiplication of that RNA that occurs, and it's an amplification process. If there are high levels of pathogen in there, they light up. So that's how you identify whether pathogens are in the sample. And by multiplex, we mean we're using a testing platform that looks for multiple pathogens at the same time.
Excellent. That's very helpful. Thank you, Dr. Goldberg. So with that, let's jump into our first case today. We have a 40-year-old healthy female who's had 3 children by normal vaginal delivery, presented for evaluation for recurrent episodes of vaginal discharge and dysuria. Her history is recurrent episodes of vaginal discharge, itching, irritation, does not recall a previous diagnosis or treatment. Dysuria, urinary urgency, and frequency, past urine cultures were negative. Reports post-colloidal discomfort. On exam has purulent discharge, ferility of the cervix, no cervical motion tenderness or nexal tenderness. Ali, you've seen patients like this before in the clinic. What are your first thoughts when you see a patient like this?
So Ben, some challenges I think of right off the bat with this patient is I can't really nail down exactly what's going on, make that really definitive diagnosis just off of her history and her exam alone. So when I'm hearing her history, I'm thinking this could be a UTI, this could be vaginitis, could be an STI, etc. So I'm uncertain, but despite that, this patient, she wants her answers fast. She's uncomfortable. She's tired of this. She's had this for weeks at this point, maybe months. And today is the day she came to my urgent care and she wants the answer now. She wants this gone today. And I've certainly had lots of patients, I'm sure you all have too, where, they've had their symptoms for weeks, months, and they come to your urgent care fed up and they're like, fix this today, fix this now. So it's up to me to figure it out. So I want to get this patient the answer fast, and I want to get it right the first time. So picking the right testing is really important here.
Yeah, the clinical confusion and the urgency that, the emotion that the patient's feeling is really important. So as we go into this and we think about this patient, Ali, what diagnostic techniques and tools do you think through, and walk us through what test results you'd expect?
So for a patient like this, there's a lot of pathogens that could be the cause. the she's having signs of recurrent cervicitis and recurrent urinary symptoms without a clear source. And so while I have the usual suspects on mind, like chlamydia, gonorrhea, BV, I have to consider the pathogens that are implicated in recurrent cervicitis. So like that's your Mycoplasma genitalium, for example. So the test that I'm thinking about in my head as I'm walking through what I'm going to do is, I think perhaps wet prep. That is typically, cheap and fast. The sensitivity, though, isn't great for trichomonas, and a lot of urgent care settings, at least the ones that I've worked in, don't have that in-house. And the same goes for vaginal pH testing. While it's helpful and can help guide me towards a diagnosis, it's not going to give me an exact answer that I need. Urinalysis can definitely be helpful to give me a clue if she has any concerns for a UTI, but I may have to wait days to get a urine culture back to get a definitive answer there too. So for me, PCR makes most sense in this situation because I can test for multiple pathogens at one time. Culture can take months to grow out those slow growing bugs like Mycoplasma genitalium. So that's kind of out. But most importantly, I don't have to wait days for the results since PCR typically has a faster turnaround time than culture.
Very good. So test results, Mycoplasma genitalium with macrolide genotypic resistance comes back. And Allie, can you give us kind of your discussion based on those findings, what your treatment plan would be and how you'd follow up with the patient?
Absolutely. For this patient, we did decide to do a rapid PCR recurrent vaginitis panel, and we had the answer the next morning, and it was Mycoplasma genitalium, where we detected that there was macrolide resistance. So I was able to specifically tailor her antibiotic choices based on that test result, and I was able to get her doxycycline and moxifloxacin and get her feeling better. What I want you to remember about this case is that after we treat this patient, we need to treat the patient's sexual partners, and it's really important to follow up 3 weeks later to perform a test and cure, since this bug has higher rates of treatment failure and antibiotic resistance. So the follow-up here is almost as important as treating the patient herself.
Great tip there. That's a great insight. And that discussion with the partner can be difficult sometimes as well. Dr. Goldberg, Mycoplasma is one of those organisms that there's been a lot of past controversy around. It's increasing in incidence. Walk us through, from a population health perspective, why we need to be thinking about this pathogen more now than ever.
Sure, Ben. And Allie presented great in-room decision-making. So we offer for the viewers some notes about epidemiology, prevalence, the diagnosis, and challenges related to mycoplasma, but I'll just highlight a few points. First, Mycoplasma genitalium is definitively a GYN pathogen, and it occurs in under 2% of cases. Certain groups are at higher risk: young women, those with bacterial vaginosis history, multiple partners, considerations like that. As Allie described in this case, antibiotic resistance is a prevalent consideration, and you have to think about that actually in the process of taking care of a particular patient. There are both first-line and second-line antibiotics, and then what to do in resistant cases, such as using a fluoroquinolone class antibiotic. And as Allie mentioned, it's really critical. You have to treat the patient and confirm a test to cure. And for the partner, you've got to get that partner evaluated and confirm they don't have any active infection as well.
Great insights. Thank you, Dr. Goldberg. With that, we have our first audience survey question. How concerned are you about rising resistance of STIs like Mycoplasma genitalium in clinical practice? While we're waiting, Allie, sometimes you have these tough conversations you have to have with both the infected patient and then possibly the partner. Any tips or tricks on how to have those conversations?
Yeah, these are really difficult conversations to have, regardless if this is someone who has come in before for sexual health testing or if this is their first time coming in for something like that. So emotions can run really high. A patient can feel embarrassed about an STI diagnosis. So I always like to really emphasize that this is common and this is a treatable condition. So I also like to frame the conversation that STI testings, it's a part of routine healthcare. This is the same, getting checked for STIs and taking care of your sexual health. It's the same and as important as getting your cholesterol checked, getting your blood pressure checked. So I like to kind of phrase it like that to kind of take the stigma off and help them feel like this is normal. This is okay.
Great tip. Dr. Goldberg, about half the audience, a little over half, is very concerned to somewhat concerned about resistance with STIs. Given the prevalence of resistance and the growing resistance, any thoughts, ideas on how testing and earlier, better responses can help address the resistance issues that are out there?
Well, first, Ben, grateful that many are concerned because it shows that they are aware. So that's really good news to hear from our fellow clinicians. I think the second thing is there's usually available data, and I know our company provides it, on what resistance looks like in a given geographic area for different types of conditions. So that's good to survey. And then finally, some results offer out the observation of a genotypic resistance based on looking at the DNA or RNA of the organism. So that becomes a bit of information that can be used by the clinician to not only discuss with the patient the finding, but also the treatment planning.
Excellent. Thank you very much. With that, let's go to our next case. And here we have a 22-year-old female that presents with a 5-day history of abnormal vaginal discharge, dysuria, and labral irritation. Her history is she's sexually active, new male partner within the past month, history of inconsistent condom use, history of past UTIs, physical exam, erythema, and mild swelling of the labia. Patient reports it's painful on palpation, no discrete lesion though. Watery clear discharge in the vaginal vault. Exam the cervix and anexa is unremarkable. Point of care testing was done and both came up negative. Allie, here's the classic, young girl in college, came back from spring break. A week later, things aren't going well for her. She's scared. What are your first thoughts in a case like this?
Like you said, Ben, this is a young female patient. She's probably anxious and she doesn't know what's causing her to feel this way. And she clearly has signs of a GU infection of some kind. She's got a lot of different symptoms. And I actually don't think the clinical picture is exactly straightforward. She's having some pain with urinations and she's had past UTIs. So does she have a UTI? Maybe, but she also had a negative urinalysis in-house. So I'm less suspicious for that. She's having vaginal discharge. So chlamydia, gonorrhea, trick, BV, the usual suspects. Or, another consideration is this HSV. She's having labial pain and redness, or is this something else entirely? So there's a lot of different pathogens floating in my head. So now I have to decide what's the best diagnostic tool that I have access to really nail down exactly what's causing her symptoms and her discomfort.
So let's look at that. What are the diagnostic options that you think through in a case like this? Because there are so many pathogens you need to be concerned about. It makes it challenging. You have bacteria and viral pathogens. Walk us through your thinking from a diagnostic standpoint.
So like our MGent case earlier, molecular testing really would be the best way for me to get both fast and accurate results for the STIs and the vaginitis pathogens I'm thinking of. So that's high on my list, especially for the things I'm suspicious of. So her urinalysis was negative. So again, less suspicious for UTI right now, but while she doesn't have a genital lesion in this case, if she did, I would definitely consider a viral culture of that lesion. But keeping in mind that culture can take days to result. So it's not entirely ideal for this patient that wants, fast answers. But since I'm suspicious for HSV as the possible cause of her vaginal discharge, I would definitely consider molecular testing for her vaginal discharge, testing that discharge directly to look for HSV. So I would choose molecular over serology for HSV in this case because I don't have to worry about picking up a past HSV infection, since I'm only interested to see if she's having an active HSV infection now. So for me, molecular testing would still be the best option in this case.
Excellent. Thank you. As you think through this case, you get your results back. What would be your treatment plan and based on those results?
Again, we actually ended up doing a lot of testing for this patient because she, we had a lot of differentials floating in her head and she had quite a few symptoms. So again, in-house urine HCG and urinalysis were negative, less concerned for UTI. She's not pregnant. For this patient, I actually did have access to a wet prep in-house. So I did it because, it was there, it was fast, and this patient wants answers, quick, she's anxious. Negative for BV and yeast. I actually was able to do a next day PCR vaginitis panel for this patient to look for STIs as well as HSV. And HSV2 is actually what she ended up testing positive for. The presumption is that this herpes virus is causing all of her symptoms, including her vaginal discharge. This was actually a real patient of mine. I was a little surprised HSV was kind of the answer, since this is an uncommon cause of vaginal discharge. But I was glad I was able to get an answer so quickly with PCR, so I didn't have to delay her treatment. I was able to get her feeling better faster. And the good news is, there is suppressive treatment available for an outbreak of genital herpes. So I was able to get her on acyclovir, just a quick course of that fairly quickly.
Very good. Thank you, Allie. So Dr. Goldberg, HSV is another one of those infections that's increasingly prevalent in the community. Walk us through, from a population health perspective, what we know and what are the patients where we should suspect this pathogen most commonly.
Sure, Ben. And for our viewers, we list there a few key facts about the prevalence, transmission and diagnosis, the impact and prevention and management of herpes simplex virus, with HSV2 being the primary gynecologic sexually transmitted pathogen. About 1 in 6 women aged 14 to 49 is infected with HSV2. So it's really quite prevalent. It's higher prevalence in Black and Hispanic populations. Possibly that's due to disparities in access to healthcare. Women are, it seems, biologically more susceptible to HSV2 transmission than men. So that is also a factor in risk. Now, for many patients, they are unaware they have been exposed. They are unaware that they carry it, and many cases remain undiagnosed, as it can be asymptomatic for a long, long time. Now, some people are burdened, unfortunately, with recurrent outbreaks and discomfort. And this can cause, as Allie described earlier, feelings of psychological distress and other. So again, the common theme about talking about sexual health is so critical. If someone is pregnant and they have an active genital herpes occurrence, you have to consider the delivery plan, because there's risk of neonatal transmission. And there's ongoing efforts that focus on education and prevention and reducing stigmata. So screening is critical, early diagnosis is critical. And that's an illustration of how, in this case, where HSV atypically was the cause of vaginitis, is a great case for multiplex PCR, where you can get a rapid diagnosis and rapid intervention to drive suppression of the symptoms. As part of our education effort through these webinars, we like to offer some kind of thoughts for the future. Although this was vaginitis and a vaginal discharge as the primary complaint of HSV, we're all aware that HSV, and in particular HSV2, can present as a vaginal ulcer. So we wanted to quickly review a differential of ulcers. We break them out in 2 different types: painful genital lesions and painless genital lesions. So there's a list of painful ones, of which herpes simplex virus is listed. There are others that listed there, including chancroid and Behçet's disease, which is a blood vessel inflammation. And then there's a differential for painless genital lesions, including syphilis, lymphogranuloma venereum, granuloma inguinale, and genital warts.
Very good. Thank you, Dr. Goldberg. Great review. With that, we have our next audience survey question. Would you consider PCR testing for this patient? Allie, we're talking about the difficult conversations. This conversation is difficult for a different reason. It's a young girl, right? She's thinking about her future and stuff like that. Any tips on that kind of conversation?
Yeah, this is a tricky one, because with the HSV2 diagnosis, I do have to inform her that while this is treatable, it's a lifelong infection that can come back up in the future. So this is something that a lot of people struggle with, and these are really hard conversations to have, and it's a hard diagnosis to give. But again, circling back to how I kind of navigate all my STI diagnosis conversations, is that this is common. Like, you are not alone. Although this is something that may come up again, there is treatment. This shouldn't impact your life in a significant way, that despite the stigma that comes with it. So I really try to emphasize that this is common. This is something people go through, and there is treatment available, just to, help with the anxiety of that conversation.
Yeah, the world isn't coming to an end.
Exactly.
Dr.
Yes.
Goldberg, it seems like our results are kind of showing that, yes, in combo with microscopy. What are your thoughts on that? And for a lot of the STI infections, PCR is the standard of care. Any other thoughts on the results we're seeing?
Well, Ben, to me, it suggests that our colleagues have a range of diagnostic testing that comes to mind and might have in the clinic. So if many are mentioned about microscopy, that certainly considers about point of care testing for urine. Some might have wet mount capability in their office that could assess for bacterial vaginosis, yeast, even also a microscopic review for trichomonas. So the way I'm reading this is folks have access to both types of testing and are considering all, which is a really good idea.
Excellent. Let's move to our last case. And Dr. Goldberg, I'm interested in this case because there's so much controversy right now around molecular testing and when, where, how to best use molecular testing in different patient types. So here we have a 78-year-old man transported from his assisted living facility with a 6-day history of dysuria, urinary urgency, and chills. On history, patient has a chronic urinary catheter secondary to a neurogenic bladder, has diabetes mellitus type 2. The patient is alert, oriented, not toxic, temperature of 99.2, heart rate of 90, respiratory rate of 18, 98 on RA, no abdominal tenderness, back or flank pain, or controvertible angle tenderness. The urinary catheter is in place. This is a complicated patient here, Dr. Goldberg. What are your initial reactions when you see this patient in your urgent care?
This is a complicated case, Ben. And that's my first reaction. And I want to make sure I get it right. And I want to make sure I can safely diagnose and treat this patient in the outpatient setting and in an urgent care setting. So to start, in this case, the patient is 78 years old. What we're aware of is that in the United States, we're confronting a silver tsunami, which is about 11,000 people becoming 65 or older every day in the United States for the next several years. We're aware of shortages in terms of access to primary care, GYN, internal medicine. So we and our urgent care colleagues are likely going to see more such cases and more complex cases. So we just have to be prepared. Diabetes is quite prevalent. It can lead, if you have it for a long time, to a range of comorbidities and consequences, including neurogenic bladder and including the need for an indwelling Foley catheter. But having an indwelling Foley catheter can put you at risk for bad stuff very quickly. So let's look at this case and try to tease through it. We're seeing a mixed picture in terms of us trying to gauge how sick this person is. So it's good that they are alert and oriented and not toxic. That's good news. They've got a bit of a fever. Their heart rate is a bit fast, but their breathing is not fast and their oxygen is good. So it's not suggesting that they are toxic. All good news. And as you described, the abdominal exam is unremarkable. At the abdomen, at the flanks, at the costovertebral angle, which can get uncomfortable if the kidneys start getting involved. So that suggests we might be early, and that's good. And then the urinary catheter is in place. Now, what's not described here is how long the catheter has been in place. But if it's been in 2 weeks, it elevates your risk of more generalized problem.
Very good. Dr. Goldberg, what's your differential here? And what are the diagnostic techniques that you think would best fit a patient like this? And this is one of the areas where there is controversy. So help us understand why you're picking it and what are the options?
Well, Ben, the thing that I'm thinking with a lot of energy as I'm in the room with this patient is trying to assess how sick they are and how broad the infection might have gone beyond, say, seeing if they have it in the bladder. So I'm concerned if they have an early pyelonephritis that it extended up to the kidneys. And this person certainly has risk factors because of the indwelling catheter for having multiple organisms in the bladder as pathogens. Yikes. And it's not uncommon that these multiple organisms can be antibiotic resistant gram-negative organisms, such as E. coli and others. So that's a concern I have. So then I need more than my own thinking to help make an assessment of what's going on. We'll take a look at a urine dipstick, a urinalysis. We'll consider a urine culture But the problem is the urine culture is going to take multiple days. I'm concerned that this patient's condition can escalate fast. So in my opinion, I can't wait for that. And that's where multiplex molecular testing, looking for multipathogens with rapid result turnaround, can help me do best care for this patient. So I'm going to consider a multiplex urine PCR test in this patient.
Excellent. So with that, Dr. Goldberg, walk us through your diagnosis and what you've done and where you think this patient's headed.
Well, Ben, we thought about what's going on, mild to really sick. We're concerned about progression to pyelonephritis or urosepsis, which can be life-threatening. So we're going to go ahead and get that multiplex urine PCR test. And our results show in this patient that they had multiple gram-negative organisms, E. coli and Pseudomonas. And sadly, in terms of risk profile, they were multi-drug resistant. So that's yikes and yikes. Frankly, I need help in terms of consultation on the therapeutic planning in terms of antibiotic regimen. Possibly this patient with careful follow-up can be managed as an outpatient setting, but there's going to be a short trigger to escalating the level of care depending on how they're doing in terms of their vital signs in response to therapy.
So this is where you phone a friend, right?
Phone a friend, absolutely. And don't feel bad about it.
I think that's a great call right there for this type of patient, for sure. So Dr. G, walk us through from a population health perspective. Earlier, you mentioned the silver tsunami. Clearly, we're going to be seeing more of these patients. Help us understand, where does PCR best fit in, and when does culture fit in or no testing fit in?
Well, catheter-associated urinary tract infections are going to be something we in the urgent care setting are going to see more of. We need to understand the morbidity associated with it. Bacteremia occurs in 5 to 10% of patients with catheter-associated urinary tract infections. That is high. That is a lot. That is a bunch of folks that can get sick and sick real quickly. The risk factors are long-term catheterization. So if the catheter is in there longer than 2 weeks, if they're elderly, if they're immunocompromised, if they have diabetes and certainly progressed diabetes. And a major thing that we can do is if someone needs to catheter, hopefully they've been coached and managed about how to do very good personal and local care of that catheter. There are several pathogens. We list 5 here that are associated with the bug. And we mentioned preventative measures. So in terms of PCR, there is accumulating evidence about the value of PCR and multiplex PCR to help make upstream diagnosis accurate, reduce downstream visits, and total cost of care. Now, for me in the clinic, and someone who I know from reading is at risk for multiple organisms and multiple resistant organisms, I want to get that answer fast. I don't think I can wait several days for a culture. So to me, this is a profile that's excellent for the use of multiplex PCR to help get the diagnosis promptly and an effective treatment plan, given the morbidity that we're confronting in this profile.
Great job. Thank you. When managing a patient with suspected UTI, what is your usual approach to initiating antibiotic treatment? Allie, I'm sure you see a lot of UTIs in the pediatric population where you work primarily. Any tips on UTIs in that population?
Yeah, kids can be tricky where, they may not be able to, depending on their age, be able to tell you exactly what's going on. And we just have to make the best guess based on their history and exam if, we're suspicious for UTI. So I really, really have to rely on, for those really young patients, on like initial point of care urine dipstick or urinalysis testing. If I get a really good specimen and it is completely squeaky clean negative, it makes me more reassured that maybe I need to go look on and figure maybe it's a different diagnosis. Maybe I need to go on to a different path. But if that point of care test is fishy at all, or I'm looking and there's a lot of leukocytes or nitrates, I really have to investigate that further and be highly suspicious at that point. And I think kids also, kids, they can be prone to pyelonephritis. They can get sick very fast with UTIs, especially febrile UTIs. So Like that patient that we just discussed, I always have my guardrails up, my red flags up with the little ones coming in. So I really rely on my point of care testing, and I really need to confirm it. And kids can get sick fast. They could look really well and they get sick and decompensate fast. So multiplex PCR is a really good option for those kiddos as well.
Thank you, Allie. Dr. Goldberg, any closing thoughts on this case or the survey results?
Yeah, Ben, I would say I talked about one spectrum of age and morbidity, and Allie talked about another spectrum of age. There can be people right in the middle who have no complicated medical history, have classic cystitis symptoms in a female. We get some insights from point of care testing. We know about the resistance in the community. Let's hope it's not high. We're probably safe to initiate treatment just with that information and then do some follow-up afterwards. So for folks in the middle, they're probably okay with historic established point of care testing. It's when you get at the spectrums that you want to consider something else, especially in the elderly where the morbidity risk is very high and you got to get it right very quickly.
Yeah, the sicker the patient, the more that ability to wait and the need for answers to be right really kind of gets amped up. Great conversation. Thank you both. In wrapping up, we know that PCR is the gold standard for certain sexually transmitted diseases, as it is for certain respiratory viruses. We're seeing higher rates of E. coli resistant UTIs, and Mycoplasma genitalium is growing in resistance and is now a known pathogen to be tested for. You know, Allie, I thought the case about the refractory vaginitis was very insightful, highlighting the important role that Mycoplasma is playing there. And then the herpes case with, when you have active lesions, it's easy to swab that lesion, but finding the right test and being able to get the right results, the serology test, and not always having or detecting a past infection was very interesting. As far as the UTI case, Dr. G, I thought your insight on the catheter and the fact that we're going to be seeing more and more of those types of patients is really important, because that's a patient that in the urgent care we need to become more familiar with. If we're not seeing a lot of them today, we're going to be seeing more of them in the future. And then tailoring your treatment based off of the severity of illness of the patient and what their progression looks like. And then, patients want answers fast. I think that's one of the things post-COVID is everybody wants answers yesterday. And playing that clinician and making your patients happy becomes really important. With that, we'll open it up to questions. And I do have two questions real quick. Allie, you mentioned wet prep for trichomonas and some of the issues there. Can you kind of give us a little more background on that, and when, where should we use wet prep or shouldn't use wet prep?
Yeah, wet prep, it's fast. It's done at the point of care setting. So you can get answers really quick. So there are some benefits to it. It's really great for detection, a quick, fast look if we're concerned for BV or yeast. For trichomonas in particular, though, wet preps, the sensitivity can be a bit of a miss. Studies show that it can be anywhere from 44 to 68% as far as sensitivity for trichomonas. And so even after an hour after the slide prep, that can drop all the way to 20% sensitivity. So unfortunately, the accuracy for trichomonas, specifically with wet preps, can be pretty poor. And so it's not my favorite test. It's not my go-to test when I am suspicious for if trichomonas is on my differential. I would be more leaning towards using molecular testing if I really needed to flesh out trichomonas from the diagnosis. So there's a time and place for it. But if I'm going to use a wet prep for trichomonas, I would definitely, if it's really high on my differential, I would want to confirm with a molecular test.
Excellent. Thank you, Allie. And Dr. Goldberg, you did a great job of walking through the painful and the painless ulcers. One of the ones that you mentioned is syphilis. And I know that's an infection that we're seeing billboards all over. Clearly, it's a public health issue right now. The rates are going up. Any thoughts, ideas from a population health perspective and a diagnostic perspective on syphilis?
It has definitely increased in numbers. There are certain at-risk population, males, indigenous population. So we want to think about it more. Oftentimes folks come in with a classic painless lesion. It's called a chancre. We are becoming more and more comfortable with the use of multiplex PCR, taking a sample, a wipe of that, and then sending that for analysis, because most established evidence has us using indirect testing to see if someone is exposed to syphilis, that can take some time. It's a blood test. Whereas there are several studies that show very high sensitivity and specificity with using PCR on a lesion and getting the DNA from the bacteria to be able to confirm the presence of the organism. And then if you find it, you can get treatment going very, very quickly.
Excellent. Thank you. I'll open this up to both of y'all. What are your thoughts about testing broad panels versus more narrow panels depending on the patient situation? Do you want to just test for everything, or do you want to eliminate some pathogens and narrow it down to specific panels? Dr. G, why don't you give us your thoughts first?
Well, Ben, both Allie and I practice and see patients. I'll be in the clinic tomorrow. At our company, when we have our testing and we look at our testing, we try to organize it so that anything we're testing for is potentially an actionable insight for the clinician. And viral results can be actionable. The way I think about it is that if you have someone who is not feeling very well, for example, with a respiratory complaint, they're taking off from work, they're having to coordinate their professional executive responsibilities with maybe children at home. So they want to get better fast. There's a lot of pent-up demand to come in and get a specific diagnosis and specific treatment. But for some patients who present, they get identified with a viral respiratory pathogen for which there is not a specific treatment. I have found that that information is helpful when used in a shared decision-making conversation, where you share to the patient, I know you're not feeling well. I know you want a specific answer. I have that for you. But the reality is I don't have a specific treatment. It's supportive care. So if you discuss the report and share the report and have the back and forth dialogue, we're likely to emerge from that encounter with high levels of satisfaction for the patient and less likely to offer or need to offer an antibiotic that's not clinically indicated.
So what I hear you saying, Dr. Goldberg, the treat decision's important, the not to treat decision's important. And then, the third decision sometimes, do I need to have this person stay at home or not? Are they okay to go to work or go to school or whatever is another decision that sometimes can be useful by identifying that pathogen.
And again, the reason we want to be so careful about this is we're functioning in an environment where antibiotics are overprescribed.
Right.
Overall, about 30% of outpatient infectious disease complaints, 50% of respiratory complaints. So that's a lot. And given antibiotics when they're not clinically indicated, at minimum can cause side effects, at worst,
Sure.
Sets up the person or the community for resistance, which has consequence, right, about antibiotic resistant infections. So that's why we're being so careful about it.
Great thoughts. Allie, any closing thoughts?
I completely agree with everything Dr. Goldberg said. I like getting answers about viral illnesses. I see it all the time because I work primarily in pediatric urgent care. And I think it's really powerful to be able to say, when I have a parent come to me, they're like, I really think they need an antibiotic. Please prescribe me a Z-Pak. Please give them amoxicillin. And I'm like, I really think this is viral. Most of the time it is. Their exam, it looks viral to me. So I think it's a really good tool to be able to, versus me saying like, I think it's viral. Let's see how this goes. I think it's a really great tool to say, hey, mom, dad, your child actually tested positive for adenovirus. This is a virus. It doesn't need an antibiotic. Yeah. Or they tested positive for RSV, etc. I think that goes a lot farther to giving them, it's not just about, reassuring the parent, which is a big thing, but also the way I message certain viruses, maybe I'm not prescribing a medication, maybe my pharmacological management isn't going to differ, but the way I message RSV is different than how I message the expected management for the flu, for COVID, for metapneumovirus, etc. So I can give them a lot more tailored anticipatory guidance based on what pathogen they're positive for. So I completely agree. I love it as a resource for antibiotic stewardship and for just better guiding them through the course of their illness.
Calming down that parent is really important sometimes, right?
It's half the job, actually.
No doubt. Mm-hmm. Well, thank you both. This has been wonderful. Really appreciate y'all's insights. And thank you everyone for attending for the Urgent Care Association Solutions on Demand webinar brought to you by HealthTrackRx.